Good morning, everyone. My name is Thomas Klein, and today I'm going to be presenting my research proposal, which is on predicting treatment outcomes in radiation therapy. So specifically, we're going to look at validating and developing a number of spatial dose toxicity models to be incorporated into treatment planning down the line. So my supervisors are Martin Ebbett, Pejman Roshan Fazad, and Suki Gill. So as an introduction, external beam radiation therapy involves the delivery of high-energy ionizing radiation to the target externally via a linear accelerator. So this is a proven and well-established technique for the treatment of localized cancers, and in particular, it is one of the standard approaches for the treatment of medium to high-risk prostate cancer. Notably, the dose which we're capable of delivering to the target is necessarily limited by the dose delivered to the surrounding healthy tissues, which can cause treatment-related side effects or toxicities. And toxicity remains one of the biggest impediments to the efficacy of radiation therapy treatments. So the current clinical radiotherapy treatment planning process, which has evolved, makes minimal use of the available imaging data and also relies on the assumption that we can precisely define the patient anatomy on the acquired CT images. So the treatment planning process begins with diagnosis, where the patient will see a clinician. The clinical history of the patient can be noted. The tumour characteristics can also be noted and taken, so the type of cancer, for example, and the tumour can be staged. Following this, the oncologist will prescribe a dose, and we then move on to the imaging stage, where the patient will have a CT image taken, and on this CT image, we will have the target volumes as well as any organs at risk delineated, and we can actually use multimodal imaging to register MRI or PET images to the CT scans to try to increase the accuracy of this process. So following the delineation of the organs, these are then reduced to a vector representation, and the 3D dose delivered to these organs is represented by a simple metric, which is the dose volume histogram, on which the radiotherapy treatment planning dose constraints are based. So through solving basically an optimization problem through repetitive iteration, we end up with the 3D plan dose distribution, which we then try to deliver as accurately as possible to the patient. So due to sort of the restrictive nature of this approach and the need to use the dose volume histogram, we have traditionally assessed organ dose response through this DVH, which describes the percentage of an organ's volume receiving a particular dose. So notably, by comparing the dose volume histogram between groups of patients who present with and without a particular toxicity, we can identify the sensitivity of an organ to a certain range of doses, as well as the volume of an organ which must be irradiated in order to induce a certain toxicity endpoint. So in addition, normal tissue complication probability modelling has also been used based on the DVH, which takes radiotherapy dose data in combination with patient factors and builds statistical models to predict the likelihood of radiation-induced toxicity. So common models include the Lyman-Kutcher-Berman, relative seriality, and logit model, which are shown on the right here, and all of these models involve fitting a sigmoidal-based dose-response function to the whole organ DVH data and attempt to assign a scalar probability to the likelihood of an organ developing a particular toxicity. So reviews of studies on DVH analysis, as well as reviews of study on DVH analysis, as well as on these NTCP models, such as importantly the reviews conducted by the Quantec group on which modern dose constraints are based, have provided us with practical guidelines for the optimization of treatment plans based on the dose volume histogram. And these have been adopted clinically in the form of our dose volume constraints. So as mentioned, these are specified in terms of the DVH, and for example, such a constraint might require 100% of the target volume to receive 95% of the prescription dose, or a restrictive constraint on the bladder may limit 15% of the bladder volume to 70 grays. So despite these studies and these relationships, the simplification of the dose volume relationship through the DVH causes us to lose the relationship between spatial the spatial relationship between dose and toxicity, which results in a number of limitations. So the first is that by considering only the dose to the organ volume rather than the dose distribution, we lose the spatial distribution of dose across the organ and we ignore any heterogeneous intra-organ radiosensitivity associated with those organs. We also note that DVHs exhibit a spatiotemporal degeneracy, so two DVHs for organs which have different spatial dose distributions could be identical. And this causes issues with model exportability to other treatment sites and treatment techniques. And lastly, due to the nature of how dose is deposited, adjacent dose volume histogram bins are expected to be highly correlated, which causes large standard errors in modeling and affects the model robustness. So these limitations likely explain why dose volume histogram models have a limited ability to make accurate predictions. However, new spatial models have been developed and will be developed as part of this project to incorporate the spatial correlation between the patient anatomy and the dose, which is capable of significantly improving outcomes predictions, which could result in improvements to dose volume constraints, reduce treatment-related toxicity, and improve patient outcome. So generally, these models for predicting toxicity will take the patient's clinical history data as input, as well as the imaging and structural information. So the simplest class of these models are based on the dose volume histogram and include the NTCP models introduced earlier. Other models have performed logistic regression based on the DVH bins for toxicity outcomes predictions and have used either the whole organ DVH analysis, as in the studies reviewed by Yaya in 2016, or sub-region-based DVH analysis, as in a study by Ebbett in 2015. Functional analysis has also been employed, which basically represents the entire dose volume histogram as a single continuous curve and removes the issue of correlation between adjacent DVH bins. So more complicated models, which move away from the dose volume histogram, involve the use of dosiomics or radiomics, which basically involves the extraction of high-level statistical features from the 3D CT or dose data. And these features are then used in the workflow of feature reduction and modeling, and authors have used both logistic regression and support vector machines for making toxicity predictions on these features. Similarly, we also have dose surface maps. So these are 2D maps representing the dose to an organ surface, which are created by virtually unfolding the organ surface. And similarly, authors have also used these dose surface maps to make predictions of treatment-related toxicities. So authors such as Chen and Butner have extracted geometric descriptions from these dose surface maps to describe either the lateral or the area or extent of the spread of dose. And Chen et al. Extracted a large number of dosiomic style parameters for the same purpose. And these extracted features can then again be used in the workflow of logistic regression or machine learning for toxicity predictions. Other authors have registered these dose surface maps to a common coordinate system to allow for direct pixel-wise comparisons, and other authors still have utilized deep learning techniques such as ensemble learning or convolutional neural nets for the prediction of toxicities based on these dose surface maps. So lastly, we have the use of 3D registered dose surface maps. So this is a voxel-based analysis where the 3D dose distributions need to be registered into the same common coordinate system. And from this, it's possible to identify regions where statistically significant differences in dose between patients presenting with and without a particular toxicity endpoint occurs. And by taking level sets of these significance maps, authors such as Milona et al. Have been able to identify symptom-specific subregions in the bladder for which the DVH data is more predictive of certain toxicities than the whole organ. Other authors, such as Marcello recently, have performed a voxel-wise analysis without requiring any prior delineation of organs, and have also produced 3D maps illustrating the spatial correlation between the dose and anatomy. And we plan to use a similar method to generate a probabilistic atlas for complication estimation using the methodology developed by Palmer. for this project. So, in particular, these models are capable of significantly improving the outcomes prediction. And as a specific example, Milona demonstrated that the dose volume histogram for these symptom-specific subregions were more predictive of toxicity outcomes than the whole organ dose. And other authors such as Rossi, using the doseomics approach, have found that doseomics parameters yielded statistically significant improvements for the prediction of gastro-intestinal toxicities. However, despite this, a majority of these models have not been validated, and that really limits translation to practice for these models. And in particular, few attempts have ever been made to incorporate these models clinically because they can't be readily incorporated into the treatment planning process. So, one important point is that due to the increased flexibility and complexity of these models in describing highly non-trivial relationships, these models are particularly prone to overfitting, which means while a lot of these models may demonstrate good internal validation sets in the studies they were derived, it's likely that these models would translate poorly to alternate data sets, which is why an external validation is essential. So another issue is that no matter how accurate or advanced our toxicity models become, they'll always be limited by the false assumption that we can precisely define the patient anatomy. So this assumption is inherently false, as CT scan images are subject to inherent uncertainties and also only represent the patient's anatomy at a single point in time. So margins added during radiotherapy attempt to account for these uncertainties, but they also result in the delivery of dose to a larger treatment area and limit the precision with which we can deliver our radiation therapy. So, notably, the uncertainty associated with observer-based delineation has been shown to be one of the largest sources of error in the entire radiotherapy treatment chain. So if two observers were to delineate the same structures, you would get two different plans biased separately by each of those observers. And in large clinical trials, even when participants were provided with an atlas, contouring agreement has been found to be very poor, with major deviations noted in 30% of evaluated treatment plans in one study. So this delineation error is carried throughout the entire treatment planning process, and in particular, the accuracy with which we can predict toxicity from these dose toxicity models is limited by the accuracy with which the organs at risk they're trying to make predictions on are defined. So, with advancements in modern radiotherapy, such as IGRT, IMRT, SABR, which is being increasingly utilized in prostate treatments to spare the rectum and bladder, modern treatments are increasingly being characterized by a high gradient in dose fall-off, and this is exhausting the ability for our DVH-based toxicity models to accurately make predictions. So to illustrate this point, we note that for treatments characterized by high dose gradients, a geometric miss of the target will actually result in a greater decrease of dose delivered to the target. So in this exaggerated example, if we assume that the open circle is the real CTV and the filled-in circle is the true CTV, we see that as our treatments become much more conformal, we actually get a geometric miss of the target, whereas with a less accurate treatment, we wouldn't. So for this project, we're fortunate to have access to the entire conventional versus hyperfractionated, high-dose, intensity modulated radiotherapy for prostate cancer trial, CHIP, which is the largest clinical trial data set for prostate radiotherapy. It contains full treatment planning information, so CT images, delineated structures, dose distributions, as well as comprehensive GU and GI toxicity data, which has been graded using the RTOG toxicity grading system and the Lent-SOM grading system. So this data set is much better than previously available data sets for a few reasons. So firstly, the large size provides us with a high statistical power in modeling and is going to let us explore approaches such as convolutional neural networks, which previously couldn't be explored due to size of data. Secondly, we have a high diversity in the treatment strategy, the irradiation technique, and dose fractionation, which is going to provide us with a diverse range of features to train our models on, which should aid in robustness and exportability. And lastly, the comprehensive toxicity data is going to give us a very large range in model outcomes, which will allow us to assess a lot of different model endpoints. So to investigate the issues identified previously, we've identified two major project aims, and the objectives to be completed as part of this project will be given below. So the first aim is to comprehensively validate spatial pelvic radiotherapy toxicity models using the largest and most diverse dataset, which is the CHIP dataset. And the first objective will involve the validation of existing models, while the second objective will involve the derivation of my own models, or derivation of new models. Aim 2 is to transform the conventional radiotherapy planning approach to a new robust process that can capitalize on emerging computational techniques. And the only objective under this aim I'll complete is the adaptation of toxicity models to incorporate spatial uncertainty. So further research will involve the development of a voxel level framework and the evaluation of how these models actually perform in the treatment planning system, but this is most likely as far as I'll get in this PhD. So for the first objective, where we want to validate the existing models, we'll require for each model, we will need to compare the predicted likelihood of toxicity incidence to the expected classification. So this will require establishing the equivalence of features and toxicity outcomes between each of our models and the CHIP dataset. So as a concrete example, for the model considered by Mylona, where she showed that symptom-specific subregions, the dose volume histogram of these regions was more predictive of certain toxicity endpoints, we would need to extract the DVH data from the same subregion on our patients in the CHIP dataset for the toxicity endpoint we were trying to validate. So we would do this by translating the entire CHIP dataset into the same common coordinate system used in the study by Mylona, applying these symptom-specific subregions, which can then be mapped back into the patient space so we can extract these parameters. So secondly, we will need to establish the equivalence between toxicity outcomes, and for this purpose, we can classify or grade toxicity outcomes or generate global toxicity scores. So as another example, if we consider the dose surface map studied by Buchner, the toxicity grading system was dichotomized into either a grade 1 or grade 2 toxicity versus no complication, and one of the considered endpoints was rectal bleeding. The authors gave a grade 1 rectal bleeding to be defined as occasional, while they defined grade 2 as requiring transfusion or surgery. So if we compare this to the Lent-SOM or RTOG systems, which we have in the CHIP dataset, we can see that under the Lent-SOM scoring system, occasional rectal bleeding is defined as a grade 2. So our grade 2 toxicity under this system is the same as their grade 1 toxicity, while under the RTOG system, occasional rectal bleeding would be a grade 1 toxicity. Also notably is that where toxicity endpoints are ambiguous and can't be directly related, we'll most likely equate the patient outcomes by matching the number of patients in the toxicity group rather than drawing from these ambiguous sort of grading systems. So assessment of the predictive ability of these models will be done through the area under the receiver operator characteristic curve, which is a plot of the sensitivity versus the specificity, and provides a thorough description of the model performance, which is insensitive to data imbalance, which can be a problem in medical data sets. We'll also generate calibration plots, which can give us an indication as to whether the model is overfitting or underfitting, with a perfect calibration being a straight 45-degree line. So we can then assess the model discrimination and calibration with the Bria score, which is the mean squared distance between the actual prediction and the predicted outcome. So notably, by permutation sampling sort of random subsets of patients in the CHIP dataset, we can also get measures of how likely the observed calibration and discrimination would be obtained by chance, which establishes the robustness of our models and gives us a measure of the significance. So the second aim is to develop our own models for predicting toxicity. And we'll explore two novel approaches for this purpose. So the first will be toxicity prediction from voxel level mapping. So as stated previously, Marcelo has identified spatial dose toxicity maps, which do not rely on any prior delineation of structures by observers. And this was achieved by registering all the patients into the same common coordinate system and performing voxel-wise comparisons. So these sort of maps offer a high level of information which could be incorporated into treatment planning. However, these maps were not translated into a measure of relative risk due to the size of the dataset in Marcelo's study, and currently we can't incorporate these maps for treatment plan optimization. So for this project, we'll start by repeating a similar voxel level mapping as Marcelo. So we'll have n 3D dose distributions for n patients in a common coordinate system defined according to a binary toxicity outcome. So associated with each patient, we can also have a list of non-dosimetric variables such as spatially normalized anatomical maps, so the patient's imaging data, CT, MRI, etc., and a list of significant patient-related factors, so like age or smoking status. And this will be used as our starting point to generate a probabilistic atlas for complication estimation using the PACE method presented by Palmer. So this model basically relies on as many logistic regression models as there are voxels. So for each of the n values of local dose and for each covariate, we take a logistic regression for predictions of the binary outcome, which forms our model backbone. So the n patients' outcomes will be tied to the local dose for every voxel through a logistic regression model. So we end up with a set of m generalized linear models, which allows us to predict parameters such as the volume effect, the shape of the sigmoid response, or the tolerance probability using maximum likelihood estimation. So for an unknown patient, to make PACE predictions, we can then compute the regression value and its confidence interval on a voxel by voxel basis using this model backbone, which provides us with a map of probabilities and a map of their weights, which we can then sum up in a similar fashion to the Lyman-Kutscher-Berman model to get our PACE probability, which is our radiation-induced morbidity map. We also plan to investigate deep learning techniques. So this is an unsupervised learning technique which doesn't require any prior selection of features. We note that this is a very deep learning architecture with each neuron in a convolutional layer not necessarily connected to all neurons in the previous layer, such that the model can focus on low-level features in the first layers while progressively assembling them into higher and higher level features. So when attempting to train a convolutional neural network, one of the biggest issues we face with medical data is data imbalance, which obviously occurs due to the scarcity of patients which may present with a particular toxicity. So learning through imbalanced data is a problem because the model may attempt to predict on the majority of non-toxicity patients to obtain a higher accuracy, which gives us overfitting and poor sensitivity in finding the minority outcomes. So to overcome these issues, we'll use most likely a popular technique known as AdaSyn, which allows us to generate synthetic minority data using an approach presented by He in 2008, whereas other approaches might involve the use of batch normalization or the introduction of dropout layers. So authors have previously demonstrated the feasibility of convolutional neural nets for the prediction of treatment-related toxicities using 2D dose surface maps. However, in these studies, due to insufficient dataset size, the models were pre-trained, and these were basically only studies in feasibility with no validation performed. However, for this study, this won't be necessary because we'll be able to train our CNN from scratch with a large validation set to evaluate model performance during training. So for this project, we'll use the VGGNet 16 CNN architecture initially, which has the advantage of being a relatively simple architecture, but also has been shown to perform extremely well at image recognition tasks. So, as I mentioned, it has a relatively simple architecture consisting of 2 convolutional layers followed by a max pooling layer, and that just repeats through the network. These max pooling layers downsample the image, reducing the computational load and help to add translational invariance, which is very useful for classification tasks. And we feed the output of the final convolutional layer, so the learned feature maps, into a regular multi-layer perceptron for a binary toxicity outcomes prediction, which provides us with an indication of the likelihood of classifying a patient into a toxicity or no toxicity group, and provides us with a measure of risk for the optimization of treatment plans. So as in Zen, we will most likely train these maps initially, train these CNNs initially using the dose surface maps, but because the receptive field of a neuron extends across all previous layers, a convolutional layer with N filters will always produce N feature maps, which opens up the possibility of including the correlated imaging and dosimetric data as a stacked, well, basically as a 3D matrix of 2D layers without significantly increasing the model complexity. So these approaches may not be feasible, but they'll also be investigated. So internal validation of these models will then be completed on a subset of the chip dataset to which the model was initially blinded, with the possibility of performing external validation down the track on other datasets. And the risk estimates obtained from these models can be obtained compared to our models from Objective 1. So the last objective will be to validate the models in Objective 1 and Objective 2 within a framework incorporating spatial uncertainty. So previous investigators have established a reference atlas of 5 representative patient datasets based on MRI data, providing the best coverage of a target set of 711 pelvic CT images. We have had 13 independent observers delineate these CT images, performing probabilistic maps representative of the patient anatomy. We want to propagate these maps to the entire chip radiotherapy dataset, which will allow us to assign each voxel with a probability that it represents a particular tissue type. So this moves away from current clinical practice of requiring precisely defined observer delineated anatomy. And notably, we want to assess the ability for these models to predict toxicity under this framework through a statistically weighted assessment of relative risk. So for models which do rely on the structural information, we can work out the risk of toxicity across the range of anatomical structures and take a weighted average, whereas for voxel-based models like the PACE model, we can just weight the risk calculation by the likelihood that a voxel represents a particular tissue type. So the predictive ability of each of these models can then be evaluated as we did under Objective 1, and we can make comparisons of models under this framework as well as between the same model with and without incorporation of spatial uncertainty. Just thought I'd quickly flash up my project timeline. So as you can see in the logistics section, things like ethics approval and whatnot will hopefully be completed within about the next month. The overall length of the project is about 40 months, and Objectives 1 and 2 can be completed simultaneously, while Objective 3 will follow sort of towards the end of those other objectives. As well, just to quickly show you my budget, in particular, there's no cost associated with publication because we don't expect journals we publish to have any fees. All training has already been completed, and the largest expense is travel, but I don't expect I'll use this much money. I've just put it into the table because I have it through my scholarship grant. So in conclusion, this project seeks to address 2 of the current major limitations in radiotherapy, which is the inability to account for the spatial distribution of dose across an organ and the observer delineation error. We're taking the first steps towards applying these spatial dose toxicity models in treatment planning, and the incorporation of which will allow for better predictions of toxicity, better dose constraints, better plan optimization, and reduce the healthcare cost burden and improve patient outcomes. Lastly, the evaluation of these models under a framework incorporating spatial uncertainty serves to shift away from the current radiotherapy treatment paradigm and will provide the foundations for calculating toxicity risk under a voxel level framework, with the final result after the end of all the studies for this aim being a validated and robust methodology for personalised radiotherapy treatment planning. Thanks for your attention.
Yes, are we still recording? So, I have a question. So, I think you jumped a little step where you went from, to not using spatial information, not conjuring, as in not conjuring the organs at risk, and I wasn't fully sure how you plan to do that. It went from one slide to the next slide, and suddenly you said
Yeah, so you mean this objective 3, adapting toxicity models for spatial uncertainty?
No, I think it's further down. No, it's go slide 27 or something like that.
Slide 27.
Yeah, that one. Go back. Yeah. Moves away from current practice in which require definitive delineation of patient anatomy.
Yeah, so that was for objective 3. So instead of having basically you have your patient come in, you define their organs and you develop the treatment plan based on the delineation, we're proposing that if you had a reference atlas which was sufficiently representative of the entire, pelvic radiotherapy data set. So I think in a study by Angel, she showed that this 5-patient representative atlas provided adequate coverage of an independent data set of 711 patients. So if you assume you can generate a reference atlas that sufficiently describes the patient population, and then you have a large number of independent observers perform delineation on those atlas sets, you basically end up with a probabilistic atlas for treatment planning rather than requiring an observer to delineate every individual patient.
So that would be similar to me putting an apple on your head, your head, your head, your head. And I go, you know what, I'm just going to shoot the average height of everybody's head and hope that you manage to get the apple and not between the eyes.
Yeah. I mean, it's obviously an assumption that you can describe these patients, but Angel has actually showed that this data set was able to describe a completely unseen independent data set of 711 pelvic CT patients. Well, not completely accurately, but to a high degree of accuracy.
It would be less accurate to do this, as in you create one reference atlas for everybody.
Yeah, I'd imagine...
You're not talking about auto-contouring, are you?
No, not auto-contouring. We're talking about probabilistic treatment planning. Yeah.
So there's a joke about 3 men who go out to hunt deer, and the first guy shoots 5 meters to the left, and the second guy shoots 5 meters to the right, and the third guy is a statistician, and he says, "Yeah, we've got it." And I'm like, so that's pretty much, that would be way less accurate than a human being actually.
Yeah, well, I suppose that would be the point of doing this study and validating the accuracy of it against other models.
No, but do you understand how this is not actually going to work? Like, if you put an apple on your
I believe it will work, as does Martin.
You should look at some of the prostates. Like, they are not the same. They don't have the same size. Some are 30 mils, some are 100 mils. And your rectums are all over the place. They're not the same size.
Yeah, true. I mean, that could very well be an issue that we find with the study, but I'm definitely planning to evaluate it and investigate it. We've already got these atlases. We've already got the observers. I can send you the paper.
Send me Angel's
Yeah, can do.
Mine having a look, but I think you will have difficulty doing this, but maybe I'm wrong.
Yeah, but I mean, isn't having difficulties the whole point of a PhD? So.
I would love to see how you do it. Let's put it that way.
Yeah, I mean, hopefully everything works out, and I guess we'll just have to see. But as I said, this aim will be coming after the first 2, so.
Yeah, I think the other
by the time we get here, we may have refined what we're planning on doing. I'm not sure, but I think this is most likely what we will stick with.
Yeah.
What steps do you think are required for your study to be implemented in the clinic?
Well, that was basically going back to our aims. So the third aim is I want to incorporate spatial uncertainty into these models. So this is sort of like a project that fits into a much bigger framework that sort of Martin's been working on. So basically I'm going to be developing these models which could be incorporated in a voxel-based framework for treatment planning, whereas future investigators are actually going to take the steps to basically develop sort of an object-orientated sort of interface in the treatment planning system, sort of programmed in C# for these models to then be implemented into, and then they're going to use MATRAD to evaluate the performance of these models against sort of the standard DVH models. But that's sort of studies that will come after me, which I haven't really looked too much into. I've mostly been focused on my own objectives. So,
Tom, with the CHIP dataset,
mm-hmm.
Is that just a compilation from a whole bunch of different centres?
Yes,
Like
71 different
okay.
centres,
Yeah.
and there's
So
a lot.
Is that how many different observers there would be in the delineations that are present?
Well, well, all of the centres basically plan their patients according to their own protocols. So a lot of the data is 3D conformal radiotherapy, some's inverse planned, some's forward planned. There's subsets of the data that were planned with IMRT. So that'll have to be introduced as a covariate into modelling and things like that. But the whole point is that because there's so much diversity in the treatment technique, we have a diverse data set for training with diverse sets of features, which we're hoping will allow these models to be exported more readily than previous models. Yeah.
This represented dataset you're talking about is not the whole CHIP study?
No. So what Angel had done in her study is she had a set of 39, I think, pelvic CT images with CT scans and MRI data. And then she had a target data set of 711 patient CT images. And she showed that it was possible to take an atlas from the 39 patients, which was able to describe the unseen data set of 711 patients, so we could then delineate on the MRI images and propagate those to the pelvic data set. Yeah.
So for your study, you're saying that I have access to the 3,000 something?
Yes, I'm saying I have access to the 3,000 CHIP patients.
13 of them?
Yeah. No, I have access to the 3,000 CHIP patients, and I also have access to Angel's representative atlas with delineation by 13 observers.
Angel's, it's not yours. Okay.
Yeah.
Okay.
So I'm going to take her probabilistic map. Well, this second study wasn't by Angel. I think it was done by somebody called Roach or something like that. But the methodology was developed by Angel, and we're planning to propagate basically the maps of contouring uncertainty onto the CHIP data set.
Sorry, I got
But,
it wrong. I thought
yeah.
this is...
As Suki was saying, we may have some problems with that, but for the moment, that's